looks like it's 12:02, and because we have such a information-packed day today, I just want to welcome everybody into the our Lunch and Learn series today. And we will try to hurry up and get to our featured speaker before we're going to go over a few housekeeping things. Okay, can I have the next slide? Okay, so today we're going to kick off our fall series, and I was just mentioning to the group I'm not ready for the fall yet. We still have some great 80-degree days coming, but we are kicking off today with the asthma management updates. We're going to talk about daily management, the asthma action plan, the trigger management, and device check, lifestyle prevention, warning signs, emergency preparedness, all very, very important aspects of asthma that we need continual updates on. Can I have the next slide, please? My name is Felicia Fuller. I have had decades of experience in public health. It's my passion, it's what I've devoted my life to. I've worked mainly in all my professional life in public health, but mainly in lung health and specifically in asthma for the last decade or so. I lead my own nonprofit now, Restoration and Wellness, and I'm also a member of the Chicago Asthma Consortium's board of directors, as well as the executive board of directors. And I'm, again, welcome you all here. We have a great lunch and learn today planned for you. Next slide. So I'll go over a few, like I said, a few housekeeping things about the CAC. I'll do the speaker introduction, and then I will gladly hand it over to Dr. Dharia. And then after that, if you could put your questions in the chat, we'll try to save a few minutes for any lingering questions that there may be. From there, we'll close it out at 12:30. Next slide. So, if you don't know who the CAC is, we're the Chicago Asthma Consortium. Our mission is to seek and improve the quality of life for those with asthma. I'm not going to read all of this to everyone. We bring together medical and public health professionals, business leaders, government agencies, community-based organizations, all in the hope of raising awareness regarding asthma. I definitely direct you to our wonderful website where you can go into a deeper dive into this information. Next slide, please. So, of course, we are into networking and communication. So use the chat feature as you are coming onto the call to put your name and your place of where you're coming from or any information that you would like us to know about you, just so that we have some kind of record of who's attending our meetings. Questions for the presenter, as I said, please put those into the chat and we'll try to get to most of them or all of them at the end. As any good public health person would mention, we always do evaluation. Please look at the chat feature at the end or even in the middle. Should be there, and click it and let us know your thoughts and evaluate the program. Next, we do have committees that we're always looking for volunteers and ways that people can help. Again, I will direct you to our wonderful website, but we have a community advisory board, which I'm a part of. We have community engagement, fundraising, membership, as well as professional development. These are all areas that we're always looking for additional assistance, volunteerism, and maybe just some guidance if you'd like to engage even deeper into what we are doing. Next slide. Oh, and we get to today's speaker. I'm so excited. Dr. Dharia is a new member of our board of directors for the Chicago Asthma Consortium, and we are so glad to have her. Just a few words about who she is and where she's come from. Dr. Shimoni Dharia is a board-certified pediatric pulmonologist and a division director of the pediatric pulmonary medicine at Advocate Children's Hospital in Illinois. With a career spanning clinical excellence leadership and healthcare strategy, Dr. Dharia brings a comprehensive approach to advancing pediatric respiratory care. She's earned her doctorate of medicine from Rosalind Franklin University of Medicine and Science and completed her pediatric residency at Advocate Hope Children's Hospital. She further specialized with a fellowship in pediatric pulmonary medicine at the Medical College of Wisconsin. And in addition to her clinical training, she has an MBA. She's a hot sister in my book anyway. I will, without further ado, give the floor to our speaker today, who will guide us through this asthma updates for a brief but very critical and strategic time with her. Dr. Dharia, it's all yours.
All right. Are you all able to see my screen okay now?
Yes.
Perfect. Thank you so much for those kind words, Felicia. You are way too kind. And I'm hoping that this complicated topic you learn just a little bit and, scrape the surface because there's so much more. So I'm going to try to be quick. And if you have any questions throughout, yes, please feel free to put them in the chat, or you can always reach out to me as well. Before we talk about just the role of biologics, I want to just take a brief second and talk about severe asthma. About 10% of our asthmatics are severe persistent asthmatics. And although they represent a small number of people, they have the majority of the morbidity and healthcare costs. So that's why it's really important that we address this overall as a public health burden as well. And, factors that can define the clinical phenotypes of severe asthma include the onset of age of onset, whether there is a confounding variable such as an allergy. On PFTs, are you seeing persistent obstruction, airflow limitation? How frequently are they in the hospital? How much trouble are they having? How well do they respond to their treatment? So all of those do help define severe asthmatics. And as we talk about treatment, we'll talk about which of these factors are really important and really weigh in on type of medications that you're going to use. So before I really get knee deep into all of our biologics, I feel like you need to understand a little bit of physiology and pathophysiology. And without that, I just can't really explain all of this. So what we have to first look at is our blood cells, right? So our blood cells, we have white blood cells and red blood cells. Everybody knows of them, platelets. But how do they first come out? Well, we have a blood stem cell. And I really want to take the time to focus on the white blood cells because that's what we're really targeting with these biologics. And eventually from the blood cell, we get the myeloid stem cells, a myeloblasts, and then eventually what is formed is granulocytes. And those are granulocytes are types of white blood cells with granules in the cytoplasm, which if you look at the screen, you can see these little dots within them, and they contain protein and enzymes. Three major type of granulocytes that we're going to talk about are going to be neutrophils, eosinophils, and basophils. And neutrophils primarily are involved in like bacterial phagocytosis, where they eat them and destroy them and break them down, right? Eosinophils are more involved in like allergic reactions, parasitic infections, such as that. And basophils release cytokines that also then eventually moderate the release of histamine, leukotrienes, and prostaglandins. One other gear that you also need to learn about as we talk about, you know, severe asthma and treatment is their immunobiology. So there is a type 2 high inflammation group, and then there's a type 2 low inflammation group. So the type 2 high inflammation group is the one that we typically talk about, right? They have an allergic component. There's more eosinophils in their sputum, lungs, and there's more overall inflammation that we think about. Well, that inflammation is mediated by IL-4, IL-5, IL-13. There is also another group that we talk about that has neutrophilic asthma, and they have what we call paucigranulocytic or absent granulocytic, and they're more just neutrophilic inflammation. And that is a type 2 low asthmatic, and that's more of a non-allergic component. And many people have a mixed picture where you have both T2 high and T2 low, and you can see that as well. But over 50% of the cases of severe asthma are type 2 high asthma. The mechanism of action of these medicines is very important. Now that you understand the immunobiology a little better, I think as we talk through what each of these factors and interleukins does, I think it'll make a little more sense to you. So we use these biologics because they're really good at reducing exacerbations. They, use less of our healthcare resources, right? Even though the 10% is a small number, they use a majority of our healthcare resources. So you want to help decrease that. Also, dependence on oral steroids, overall quality of life, because they're less, they have less exacerbations, they're less in the ER or in their pediatrician's office or their primary care office as an adult. Any of those, it'll help them overall with their quality of life. So let me shift gears now. And I want to talk to you about the four types of therapies that we have right now that are targeting severe asthma through biologics. Okay. So we have one that targets the IgE, then there's an IL-5, IL-4, and IL-13. They have a lot of overlap. So, but IL-4 are a receptor. And then there's also a thymic stromal lymphopoietin. And interleukins, which is IL, when you hear me say IL, they're a group of cytokines, and cytokines secrete proteins and signal molecules. So they kind of get the whole immune system ramped up, and they're secreted by white blood cells. So when we talk about these biologics, we're really kind of maneuvering the white blood cell system. So IL-5, which is one of the interleukins that's targeted, its job is to basically promote proliferation, differentiation, activation, like changes of eosinophils, right? And we know that however many eosinophils you have in your blood, you know that the asthmatics have a higher number compared to somebody who doesn't have asthma. So there's a correlation in there. So IL-5 is really looking at eosinophils. IL-4 plays a significant role in type 2 helper cells. And I have a couple of graphics coming up, which will make a lot more sense. And then eventually that plays a role in IgE, which is also an inflammatory marker in asthmatics. Or I'm sorry, in atopic allergens and asthma. IL-13 also induces contraction of the airway smooth muscles and then increases nitric oxide synthase, which is an enzyme that you see when you've heard the words FeNO before, fractional exhalation of nitric oxide. And so it increases that. Like I say, IL-4 and IL-13 have many overlapping functions, so keep that in mind. And then the last pathway is the thymic stromal lymphoprotein, or the TSLP. And that is a cytokine that plays a role in the Th2 responses and also plays a role in T2 low pathways. So when you see that coming up, you'll understand what I'm talking about. Now, the TSLP influences dendritic cell maturation, and it's also implied in cancer, IBD, other pathologies as well. So I want to take the time and really go through some of this pictorial. So when you look at this, you have any of your allergens, pollutants, viruses, smoke, any kind of a trigger that it comes to your respiratory cilia, epithelial cells, and then that activates the dendritic cells, which activate the helper T cells, okay? And the helper T cells differentiate into Th2 or type 2 cells. Now, going back, remember I talked about IL-5, IL-4, IL-13, IgE, and TSLP. So I'm going to run through this with you, and then we'll talk about which of the medications affect where. So when you look at the dendritic cell, THO and TH0 and TH2, you look at that and say, okay, well, depending on the receptors now, the Th2 then get converted into B cells that are then activating IgE, eventually have an effect on basophil and mast cells. Th2 also have an effect on eosinophils. Also, the second pathway that we'll talk about is IL-33, IL-25, and TSLP. That is the protein that affects both the Th2 high or T2 high pathway and T2 low pathways. So we're going to go through these. Now, when you look at this, remember the Th2, IL-4 and 13 are affected by dupilumab or Dupixent. The IgE is affected by Xolair or omalizumab. And then we have the mepolizumab, which is Nucala, reslizumab, and Sinclair, and then benralizumab, which is Fasenra. And then last one is the tezepelumab, and that is Tespire. So depending on where each of these acts and attacks, that is very important as you're going to talk about how do I choose these. This is another pictorial of the same thing, okay? And I really want to emphasize it. Sorry, let me go back. This one is from the European Respiratory Review, and this one is from the New England Journal of Medicine. And you can tell that, omalizumab, which is an anti-IgE, it works on your mast cells and prevents histamine release, for example. Or when you look at your uh, dupilumab. I'm sorry, mepolizumab. When you look at that, you notice that it works on your smooth muscle cells, so it prevents that bronchoconstriction. And then there is the tezepelumab or Tespire, which works both on the T2 low asthma pathway and T2 high asthma pathway. So, and it's all of these are involved in certain kinds of interleukins. All of these kind of affect your immune system, your white blood cell system in one way or another. These are somewhat confusing pictorials, but I think this one is a very easy to follow. So you understand which one's affecting basophils, mast cells, what is wrong. And we'll talk about how to pick these, okay? So since I've said so many of these names, I want to talk about the 6 biologics that are currently available for asthma. You have your omalizumab, which is Xolair, mepolizumab, Nucala, benralizumab, which is Fasenra, resilumab, which is Sinclair, and dupilumab, which is Dupixent, and tezepelumab, which is Tespire. On the slide, all of these are indicated for severe asthma, and depending on a confounding variable, some of them may be even indicated for moderate asthma. Every single one of these, except for reslizumab, is indicated for kids 6 and older. This one is only indicated for patients 18 and older. They're all subcutaneous or IV injections. Only one you cannot do at home at this point is the resalimumab. And then depending on their weight, there's dosing intervals from anywhere from every 1 week to every 4 weeks, and then you can start to space those out as well. Last thing is when you're looking at these target molecules, right? This is really important because when we talk about how we select this, if you don't understand what it is targeting, you may miss out on selecting the most useful one, the most targeted one, the one with the biggest bang for your buck for each patient. So remember that Xolair really affects your IgE. It's an anti-IgE monoclonal antibody. Nucala is IL-5, and so are Fasenra and Sinclair. They're all IL-5. Dupixent is IL-4 and IL-13. So the 3 that I talked about are IL-5 are going to work on your smooth muscle. Dupixent is going to work a little bit on both, right? It's going to work a little bit on that IgE pathway, but it's also going to work on your smooth muscle. And then the Tespire is going to help both with Th2 high, T2 high inflammation and T2 low inflammation. One last thing is Dupixent is approved for children 6 months and older if they have atopic dermatitis. So it's not approved straight for asthma 6 months and older, but if a kid has significant asthma and significant eczema or atopic dermatitis, then you can go ahead and use it for them. Okay, so this is the $1,000,000 question, right? How do I know which one I need to use for each patient? So a lot of it is guided by the patient's age, but if you remember that chart, there's also some comorbid atopic conditions that we tried. So anybody that has urticaria, omalizumab is great, right? It was the first one. It was discovered in 2003. It's been studied the most, the longest. So it's great. If they have some hypereosinophilic syndrome, then use Nucala, right? Mepolizumab. That's great too. I just refer that if there's atopic dermatitis or eosinophilic esophagitis, then Dupixent or dupilumab is really good as well. And because this is a little bit of my opinion, but I think because we have so much information on Xolair or omalizumab, it's been known to be more effective in childhood onset asthma, which tends to be more allergic in nature. But I think as we see people use these more, children use this more, I think that information will come out that maybe more of these are actually useful for all age groups and not just adults or children. And then the benralizumab and the moplizumab is more effective on, adult onset asthma or patients with recurrent exacerbations and severe asthma exacerbations. So keep those in mind. Now, I want to spend a couple more minutes, my last few minutes on, talking a little bit about how to pick these medications. Okay. So I'll start right around here where it says you have a severe asthmatic who's without daily oral steroids or oral glucocorticoids. And then you have oral glucocorticoid dependent severe asthmatics. All right. So you have one of these, right? And of course, you may have to use your clinical judgment. You're not just going to go down and say, I'm going to do this. You may say, oh, okay, I have some confounding variable or I have something else that I need to use. So as a whole, if you have low blood eosinophils and your FeNO is low, and you may have some allergic component, um, you could use an anti-IgE such as Xolair, or you could even use Tespire, right? Because it's not as much of an allergic component. If you have low eosinophils, but you have more of a FeNO component where you know that there's more of an inflammatory component, there's an allergic component, then you may want to use your Xolair. You may want to use some of your, Dupixent, the IL-4RA receptors, or Tespire. And if there's not an allergic component, then, you can either use your Dupixent or Tespire. Now, if you have a normal amount of blood eosinophils, but you're having a lot of clinical symptoms, it's a little hard, right? Because it almost says use whatever you want, right? And so sometimes you may have to say, well, how old is this kid? What kind of symptoms? What's the predominant symptoms? How frequent are the exacerbations? So that's kind of like use your judgment, see where you're at. If your blood eosinophils are really high, one, you have to make sure there's nothing else going on, right? Like eosinophilic syndrome. Because if you do have that, then you automatically know, hey, there's a specific medication that I'm going to use for this. But if you don't have that, then you have options of also using other pathways, other medications where you're looking at what is the root physiology or pathophysiology in these patients. And the best way to say if these medications are working is give them some time. If you notice it's been 3 to 6 months, I usually do closer to 6 months, and see if they have a good response. And if they decrease the exacerbations by 50%, great response. But if it's really not making a difference, and stop. Don't keep just injecting them with this biologic because they all have side effects. And instead, go ahead and try a different one. Make a better decision, stop the medication, get a CBC, get an IgE level, get a region 8, and see what is really going on that may be helpful where you can cater these medications. All right. So a couple of things as we're talking about the response to biologics. Like I said, some patients have fluctuating biomarkers and some don't. So sometimes these tests may be useful and sometimes it's not. But higher, if you have a higher blood eosinophil count, it usually is a good it's a good indicator that you'll have a response to some biologic, right? If you have higher FeNO, then you know that you may want to pick some of the more inflammatory based one, Dupixent, Xolair, depending on that, even Tespire. If you have a higher IgE, Xolair might be good. But if you have a sky high IgE, for example, it doesn't mean that, oh, automatically go to Xolair, okay? Because in the past, and we know this based on what guidelines we use Xolair with, they say it's not always the best predictor of, response to Xolair. Now, side effects, I gotta touch on them, right? Because you're injecting these kids every month, every few weeks, you need to know. So the most common thing is just injection site reaction, like induration, erythema, all of those. But there's some rare ones that you have to know. Anaphylaxis always being one of them. Dupilumab, you can see conjunctivitis, transient eosinophilia commonly, but less commonly, you can also see eosinophilic granulomatosis with polyangiitis. And then Xolair, Nucala, and benralizumab can give you headaches. Tespire can give you pharyngitis and arthralgias. This was just an overview, but in 2022, New England Journal of Medicine came with its first article that was a review article, and that talked about severe asthmatics and the biologics. And then Annals in 24 came out one for pediatrics as well. And lastly, the European Respiratory Review just came out with one earlier this year that talks about all of these. And I think in the first New England Journal, Tespire may not have been out. It was in the pipelines, but it wasn't out. So just kind of keep that in mind. And my last slide is really to talk about like future directions. What are we going to do? How do we get everybody to use these if they qualify for them, right? Because there's so much race, gender, socioeconomic disparity, public coverage versus private insurance coverage. I think this is the future of asthma, and we really should talk about how can we get this, because maybe starting some of these early biologics may modify the path of our severe asthmatics, and overall we'll see less. I don't know 100%, but these are things like food for thought type of thing. So,
Wow, that was great, Dr. Daria. Does anyone have any questions? And I'm just want to remind everyone to please put their name in the chat so that we can have your name and your information. Any questions? If there's not, I got a couple of questions, or just to some points of reflection.
Felicia.
Biologics. Mark, did you have a question?
It's more of a statement.
Okay, go ahead.
As in retail pharmacy and actually having a wife that had allergies, and what I get disappointed in every conference I've been to is never a discussion of constant evaluation of triggers in home and work environment. Because if you don't address the triggers, you're going to be constantly with experimenting which biologic is best. And it becomes really critical for educating the patient to take control of those environments. So it's not just the medication, they've got to really assess what are those triggers and how they can minimize them.
Yeah, I completely agree. I think that, that is the basis, right? Before you even get to biologics, elimination of your triggers or minimizing triggers, right? You can't eliminate every virus or take down every oak tree on this planet. But if you can really minimize your viral triggers, you may not even get there, right? And so that is the first thing we do. Even with our mild, persistent or intermittent asthmatics, we really talk about improving their environmental triggers, home, outside, schools, because school gyms are a source of dust, or like for adults when they're driving and smoke and smoke exposure with their peers. All of those things are very important. So I completely agree. I think the first and foremost thing before you even get to biologics or even multiple glucocorticoid, systemic glucocorticoid or oral or inhaled, you really should be addressing triggers for sure.
For sure. I know at the beginning you were talking about the type high and type low asthma. Is there, or even to know if it's inflammatory or an allergic response? Is there a blood test that you kind of look at before you say, okay, this person is this type of asthma, so I would give them this type of biologic?
Yeah, I mean, a CBC is a good place to start out with, because if you have
Okay.
high eosinophils, IgE
Mhm.
is another standard test. Like if you have an elevated IgE, region 8 we do for allergies to look at environmental allergies. Food allergens obviously is self-explanatory. So you can take a look at some of these other factors. Also, clinical, I think, is very important, right? If a person says, every time I'm outside and in the woods
Right,
going for a walk, even if your allergy panel's negative and everything's negative,
right.
that's still a clinical symptom that
Mhm,
you really need to take high into account.
mhm. But would you know if that person's severe or moderate, or does that matter if they're really having a hard time,
Yeah,
even when
so
they're out in the forest? per
You know,
se?
I think the severity is really assessed on frequency of symptoms. And
Okay,
so if their
okay.
frequency of symptoms when they are and I always assess it based on like a daily basis, a weekly, a monthly, yearly basis, right? How frequent are
Mhm.
your symptoms? Because if your symptoms on low dose no medications is like once a month or every other month,
Right,
you're probably
right.
on the milder side. But if you're
Yeah,
telling me to take 5 medications and I have no symptoms, I'm not going to say, oh, this is nothing, right? That you're still
yeah.
on severe spectrum. So it really is,
Mhm.
that's more of a clinical diagnosis that you have to pursue.
Okay. And severity, the severe asthmatics about or people with asthma, about 10%. But you did say there could be people that are moderate or
Mhm.
have moderate asthma that may qualify for biologics. And in my opinion, in my world of public health, I think that's where the disparities and really looking at where the family or the family unit or where the child or adult is rotating in this planet or in this country, kind of have to give it second thoughts. Do you have any thoughts on that?
Yeah, so I mean, I think if you have moderate asthma, you're not controlled.
Right,
You
right.
have other variables that are contributing that are not really controlled variables,
Mhm.
right? Things that you're going to be exposed to regardless. That and
Right.
for example, we have patients who have moderate asthma and have severe atopic dermatitis, and they're
Yes.
on because they have
Yes.
that confounding variable. They're on biologics, and
Mhm.
as Mark will probably tell you, I think he said his partner is an allergist, right? And so that is used much more in that world than I would say in our asthma world. And now we're getting more aggressive in the asthma world using these biologics, but allergists have always been using it much more in the past.
Yeah. Or even families or kids that live by coal plants or heavy freeways and things like that. They may not be severe, but they may be moderate because of the environments that they live in. Okay.
Exactly. Smoking, I mean, that's such a
Right,
common
right.
thing for
Exactly.
most people, right? Just
Right.
smoke exposure is a big one too.
Exactly. Those were my thoughts. Rachel, did we have any questions that anyone had as we kind of bump over our time limit here?
No, no question in the chat right now.
Okay. Well, we will definitely, we're taking about 5 minutes over, and I probably could spout a few more questions, but we do want to respect everybody's time. And if we do that, we figured that you would probably come back to listen to the next month's Lunch and Learning series. As I said, we kicked it off today. We will be doing this every third Wednesday, and Rachel, correct me if I'm wrong. Um, and I'm not sure. Oh, we're doing racism and asthma next time, if I have this correct, for September. And I will also remind you that on September 18th, in the same type of format, from 12 to 1, we'll be doing a workshop updating asthma guidelines and looking at the gold guidelines. So that will be our next Zoom event. Again, we want to thank everyone for coming. Please visit our website. Please put your name in the chat if you've come. And even more importantly, and like I said, as any good public health professional, we want to evaluate how we're doing, what we're doing. If you have any suggestions or critiques, we are here to take them. Please click the evaluation button or link, and that will come right to us. So without further, do we have any other slides, or have I caught everything or mentioned everything? I think I have. Shimoni, that was amazing. Again, thank you for joining our wonderful board, and we love that your interest is with helping children in Chicago and Greater Chicago with their asthma and controlling it and keeping it in check and keeping them breathing and keeping parents working and being able to have successful and vibrant families. So I appreciate you, and I'm sure the rest of the CAC and hopefully the city does too.
Thank you
So
so much. Thank you for having me. I appreciate
oh,
it.
definitely, for sure, for sure. Um, Rachel, did I forget anything, or is that it for today, or is any other reminders that we needed?
No, no, you covered everything. Thank you all for joining today's Lunch and Learn.